Hi, Andrew Penn back here talking about anti-anxiety medications. This is our last module, and we're going to talk finally about benzodiazepines, which I know you're probably been waiting to hear. We're going to throw a little history in there. We're going to talk about what's out there and how they work, and then ultimately talk about the risks and benefits of this class of medications, which is very common in psychiatry. So if we go back in time, back to the 1940s, we didn't have DSM-5 with its 400 something different specific diagnoses. We had basically just mental illness, which was lumped into two big categories. We had insanity, which would be considered things like schizophrenia and bipolar disorder. And then we had psychoneurosis, which was anxiety, mild depression, etc. And for both of these groups, up until the 1950s, we pretty much had tranquilizers. And we had Respirine, which had some antidepressant properties, and we had barbiturates or meprobamate, which I'm going to talk about more in a moment, for the anxiety end of things. So we didn't have a lot to work with. So you've heard of barbiturates probably because they were notorious drugs in overdose. It's thought that barbiturates were what in part contributed to Marilyn Monroe's death. And so these were developed in the early 1900s as a treatment for insomnia, for nerves, really, for anxiety. And these are the barbitals, right? So phenobarbital, ambobarbital, pentobarbital, et cetera. And they're dangerous because they cause irreversible binding to that GABA receptor, as opposed to benzodiazepines, which can be reversed with sort of a Narcan type drug called flumazenil. And so because they latch onto there and they don't let go, if you saturate enough of the GABA receptors with them, they are highly lethal because they cause respiratory suppression, especially if you potentiate them with alcohol. So they're not really used much in psychiatry anymore. We see them more used in things like anesthesia and also in treatment of epilepsy sometimes. But they've really gone, they're not really used in psychiatry anymore because of their risk factors. Now, the carbamates are an interesting group of meds because this is like a forgotten class of medication. So meprobamate was marketed under the name of Milltown, started in 1955. And so it worked on GABA receptors as well. And it was enormously popular. So from 1955 to 1965, there were 500 million meprobamate prescriptions written there were only about 100 million people living in the United States at that time. So, it's like everyone had a bottle of this in their medicine cabinet, which is kind of amazing. And as you can see from this ad, we had no problem giving it to pregnant women. We had, when those kids were born, we had no problem giving it to the moms. If you can take a minute in your notes and read this whole rather troubling ad copy that really just kind of, it's quite a cultural artifact of the early 1970s. And how the intersection of the pharmaceutical industry comes into things such as feminism and overworked parents. And then in the early 1960s, we got benzodiazepines. So Librium was the first one, and they are often referred to as anxiolytic, which is kind of a funny term because it sounds like we stole that from infectious disease, like you can lyse a bacterium and the guts leak out and it dies, but that somehow anxiety has a corollary and you can pop a hole in it with an anxiolytic and the anxiety leaks out. I don't know quite how that works, but that was the term that they came up with. They're also referred to as hypnotics, and really it's the same class of meds. It really just depends on what you're using them for. So hypnotics refers to sleep medications. And these have utility in other things. Obviously, we use them as pre-op meds. We use them in alcohol withdrawal. They're good meds for breaking an epileptic seizure. And they all work as being positive allosteric modulators at the GABA A receptor, which essentially increases the ability for GABA, which is your endogenous opiate, not endogenous opiate, your endogenous ligand for that receptor to work. And when GABA receptors are activated, they open up. They're like one of those channel type of receptors, and calcium ions flow in. Those are negatively charged ions, anions, and they hyperpolarize the cell. They make it less likely to fire. Now, benzodiazepines all do the same thing when they get to the receptor. So their pharmacodynamics are the same, but their kinetics are different. So when I talk about kinetics, remember we're talking about the absorption of the drug, the distribution around the body, how quickly it gets into its target, in this case, the brain, how it binds the receptor, and then how quickly it takes to leave the body after it's been metabolized. So with benzodiazepines, the key differences are in absorption, penetration, and to some extent, um, their active metabolites. So the most important thing is probably lipophilicity here, which is that's a great name, lipophilicity, and it's essentially how quickly the molecule can penetrate the blood-brain barrier, because the blood-brain barrier is a lipid barrier. So like dissolves like. So a lipophilic drug can easily cross that barrier and get into the brain and get to work. So here's your spreadsheet, if you will, of all the different benzodiazepines that are out there. There's probably more than this. These are just the ones that are most common in psychiatry. And we have this notion of an equivalency, sort of like if you've ever done an opiate equivalency calculation. We calculate everything and convert it all to morphine equivalents. And that way you can cross-compare, say, fentanyl to Dilaudid by converting them to their equivalent in morphine. And so in this case, we make the equivalent drug diazepam. So it's commonly referred to as what's the equivalent dose of 10 milligrams of diazepam. And then I've given you the common daily dose, and then how lipophilic that particular drug is and how long it takes to come to peak. And then how long does it stay in your body? So you can see here alprazolam, which is probably my least favorite drug in psychiatry, which is Xanax, very popular in the culture, very popular in this country, but for me, a problematic drug because I see a lot of withdrawal and I see a lot of overuse of it and I see a lot of diversion. So I generally try and just not put more alprazolam out into the world if I can avoid it. It's a much more potent drug than diazepam because only 0.5 milligram is equivalent to 10 milligrams of diazepam. And it's very lipophilic, which means it gets into the brain and starts working very quickly, which is one of the reasons why people like it, which is understandable because they get relief more quickly. The problem is it doesn't stay in your system very long. So it peaks quickly and then it starts coming out pretty fast, which means you're going to have this rebound anxiety effect, which often leads people to take more of it, sometimes more than they're actually prescribed. The longer acting medications on here would be your clonazepam. You can see that's got a very long half-life on it. Flurazepam is another very long acting drug. But they have different potencies. So you can see like flurazepam is actually less potent than diazepam, whereas clonazepam has a similar potency than alprazolam. Lorazepam is probably the classic on here. So 1 milligram of lorazepam is equivalent to 10 milligrams of diazepam. And it's a drug with a lot of utility. It has sort of a moderate lipophilicity. So it does get to work relatively quickly, more quickly than, say, clonazepam, but it sticks around long enough that you don't generally tend to get that rebound effect. And then temazepam, of course, most people are familiar with its use in sleep, although really, as I said, hypnotic and anxiolytic, those are really arbitrary interchangeable terms. The benzodiazepines all have similar risk factors. So they can cause impairment in operating a motor vehicle or machinery. They can cause memory impairment. And you can see respiratory impairment when taken with opiates. So that's increasingly becoming a well-identified risk. And with older people, we have the risk of falls are much higher with benzodiazepines. So that's a good reason to be very cautious as your patients age to steer away from benzodiazepines. And also there's this increasing data, I'll show you some specifics in a moment, that long-term use of benzodiazepines may contribute to an earlier onset of dementia. And then there's the issues of dependence and tolerance, which certainly can happen, and also the abuse of these medications, often in the context of polydrug abuse. Now, I mentioned dementia as a potential risk earlier in that last slide, and there's mixed data on this. So as you see, I've got 3 studies, all from 2016 here, and I've put some of the data points on here just to show you. So in this study by Gray, the odds ratio of developing dementia was only 25% higher than those who were not using benzodiazepines. So fairly low risk identified there. But to contrast that, if you go up to this Islam study from 2016, that the rate was approaching double. So when you get an odds ratio of 2, you have double the risk from the baseline condition. And in Asia, it actually exceeded 2 times risk for developing dementia. So, I think the jury is out here, but this is starting to concern me enough that I'm rethinking my practice. And a lot of benzodiazepine prescriptions come from primary care. And this is not to bag on primary care. I love and admire my primary care colleagues because, they have to be the Swiss Army knives of clinicians. And all I have to be is like, a well-honed piece of cutlery, that does one thing, but, can cut vegetables but can't open a can. Benzodiazepines often come from primary care, and I understand why. When you have 7 minutes to see somebody and they're not sleeping and they're in a lot of distress, these are pretty reliable medications. The problem is a lot of people tend to stay on them for a long time after they've been put on them. So there's your primary care data in the bottom left. Compare that to psychiatry in the top right. And the greater concern, like I was saying before, is that co-prescription of benzodiazepines with opiates leading to potential overdose risk. Because both of those drugs can suppress respiratory drive, especially in high enough doses, the synergy of the two together really increases the risk of overdose death. So you want to be really careful not to co-prescribe those two things whenever possible. And in fact, in California, we now have a state law that says you must offer naloxone or Narcan if you are giving a benzo plus an opiate, or if the person is taking over 90 milligram morphine equivalents of opiate per day, that they need to be given and taught how to use naloxone, which I'm thrilled about because I think naloxone should be everywhere, just like fire extinguishers. There are some drug-drug interactions. The 3A4 inhibitors, the most notable ones in psychiatry would be things like fluoxetine and sertraline and nifazodone, can reduce the metabolism of chlordiazepoxide, which is Librium, diazepam, and alprazolam. And so by reducing the metabolism, you're going to have more of that drug building up, potentially higher risk for sedation and falls. And the other thing that the benzodiazepines can cause is this problem here. So remember, we went through this whole sequence earlier in the slide deck where we talked about when we're leading up to an anxiety situation. So person has anxiety, either just spontaneous or because something is stressing them out. They start to feel physically uncomfortable. They start to create narratives around that. And then normally that would just peak and subside. But if the person takes an abortive medication like alprazolam before it peaks on its own, what happens is that the patient will get better regardless, because no anxiety is going to last forever. And so it may the likely chances, especially if it gets better in the next few minutes, it was going to get better anyways. But the problem is we've now created a conditioned pairing where the person associates relief from the anxiety with having taken that medication. And that reinforces this narrative that the medication helped. And then you run into an avoidance cycle where the person thinks, well, if I don't take this medication, if I don't have it with me all the time, then I'm going to get anxious again. So the drug actually becomes a form of avoiding feeling anxiety. And then so when that usual trigger comes along, the person gets reinforced by that. And they say, see, if I had not had that Valium today, I would feel really anxious, but I'm calm. Now, it's possible that the person was not going to get anxious anyways, but it tends to reinforce that behavior. The person then begins to organize around the medication. By that, I mean, they make sure that they never run out of refills. They've always got, these are the folks that will come in to see you and they'll fish an ancient bottle of something out of their pocket or their purse, and it's, the label is worn off, and you open it up and there's like these battered, dusty pills of alprazolam or something that they've been carrying around for years just in case. So that's organizing around the medication. And this actually ends up leading to increased anxiety. So this is why I want to caution you against overuse of PRN benzodiazepines, because it really just kind of reinforces that the patient can't handle the anxiety without the drug. And this tends to lead to longer term use of benzodiazepines, which we want to try and avoid. It also sometimes runs into overuse because the person, if it's for whatever reason their anxiety is particularly bad and they've already taken a pill, they might take another one, even if that's more than what's prescribed, because they're afraid of that anxiety getting worse. That rebound anxiety is what happens when the drug wears off and the anxiety comes back, which often leads people to take more medication than they might otherwise. And then you get into these straining of the therapeutic alliance because the person is asking for early refills, and that's putting you in the position where you either have to say no and face that it might disrupt the therapeutic relationship, or they might even go into withdrawal, or that you have to, or you end up giving the person medication, additional medication, which might lead to increased tolerance and more use of the benzodiazepine. So these are situations just really best avoided whenever possible. Good ways to avoid it is to make your terms of treatment very clear right from the beginning. I like to do this in an informal contract, which is just essentially something I've printed up. I would keep them on paper, or I'd keep them as something I can pull up on my EHR. You can download one from the website. I use a similar one for ADHD meds. So really explaining what is an on-time refill, what will be my red flags. So if somebody is calling me every other month saying they lost their meds, that's a big red flag for me. If somebody is having early refills all the time, that's a big red flag. And then you need to check the prescription drug monitoring database, which is called Cures here in California. And this allows you to see all controlled substances prescribed to a person, regardless of whether they're from you or from another provider. So this prevents kind of doctor shopping behavior. Now, this question of should you ever give a benzo to somebody who's in recovery, particularly from alcohol use, is a controversial one. So there are some places who will say, you never give a benzo to somebody who used to be a heavy drinker. And there's controversy around this because it may turn out that if you actually treat the person's anxiety, and ideally you treat it with an SSRI and not a benzodiazepine, but that for somebody who's been in sustained recovery, treating their anxiety might actually reduce the probability of relapse. And so I feel more comfortable using a benzodiazepine in somebody who's in recovery from alcohol use if they have some distance, and by that I mean usually several years away from their last alcohol use. If they're currently using alcohol or they're frequently relapsing, when I say using alcohol, using it in large amounts, or if they're using opiates, I try and stay away from benzodiazepines whenever possible. So you want to also give people other skills. We want to think about what else can we offer people to treat their anxiety besides medication, because otherwise we get into this problem as prescribers where everything looks like a nail. If all we have are hammers in the form of medications, then we forget about efficacious treatments such as CBT. Now, medications certainly work for anxiety. I don't want to disparage them, but they're not the only game in town. We certainly should be referring patients for just general wellness interventions such as mindfulness meditation or yoga. Exercise is also really helpful in addressing anxiety, getting better sleep. And then also cognitive behavioral therapy is very effective for treating anxiety, particularly exposure therapy, where the person is exposed in a gradual way to the thing that is frightening to them. And these things tend to work better than medications, quite honestly, and they tend to endure because whatever benefit the patient got from therapy is going to tend to stick with them. Whereas with medications, as soon as they stop taking the medication, the symptoms generally come back. So when we compare CBT or CBT with exposure to medications, you can see both conditions are superior to medications. And the combination is a reasonable one to consider too, because it's more effective than just medication alone. So whenever possible, if you're in a system that allows you to do so, really think about getting your patient into some type of psychotherapy in addition to their medications. Now, I want you to think, if you are going to prescribe a benzodiazepine, to think about deprescribing before you even start to prescribe. Now, what am I talking about here? So first of all, if you can avoid prescribing a benzo, do it, right? If you can come up with a better alternative, don't use a benzo to begin with, because that way you don't have to deprescribe it. But when we prescribe somebody prednisone, we don't tell them, here, take this corticosteroid and just keep taking it. Try not to take too much, right? I mean, that's kind of what we do with benzos. And what I'm suggesting is, if you're going to use a benzo, have an endpoint in mind. So a lot of times a classic situation where I will use a benzodiazepine is for the first 6 weeks when I'm starting an SSRI for somebody who has anxiety and they're saying, I can't wait 6 weeks to feel better. So, okay, I can give you something that's going to help you in the meantime while this escitalopram or fluoxetine kicks in. But the expectation is you're just going to take it for a short period of time because it's not a great idea to stay on this medication indefinitely. And so I'll write this SIG, this instruction on the prescription with real clarity and say, okay, so you're going to take 0.5 milligram in the morning to address your anxiety during the day. And you're going to take 2 tablets, so 1 milligram at bedtime, help you get a good night's sleep. And then after 3 weeks, you're going to go to 1 tablet or 0.5 milligram twice a day. And then after a couple more weeks, you're going to go down to 1 tablet once a day. And then at the 7-week point, which at that point the SSRI should be kicking in, you're going to stop it. And I've calculated the number of meds that you actual pills that you're going to need for that. So I'm only going to ask the pharmacy to put 42 pills in that bottle with no refills. And this sends a very clear message to your patient that this is not going to be an ongoing treatment. This is a short-term treatment. And you'll notice those are not PRN doses. And that's intentional because if I'm treating somebody for anxiety like this, I want to remove the question of should I take the med or not take the med, because that's one more thing to feel anxious about, which your patients with anxiety don't need. Now, what about stopping a benzodiazepine? Because you're going to invariably inherit a lot of patients who are taking benzodiazepines, and for whatever reason, you might need to discontinue it. Now, if you want to do this, you don't want to do it suddenly because you can have the same kind of withdrawal symptoms that you get from alcohol withdrawal. And in severe cases, you can have seizures, you can have delirium tremens, bad news. So typically what you're going to do if you are going to attempt a tapering off is that you're going to consolidate to a single drug. So a lot of times people coming to you for benzo taper are taking multiple medications. So you're going to do an equivalency, you're going to add it all up, and you're going to convert this to a long-acting drug. Usually diazepam is kind of the classic. So for example, somebody who's taking 2 milligrams of alprazolam a day, that's equivalent to 40 milligrams of diazepam. And then you're going to taper that total dose. You can divide that up however you want. If it's 10 milligrams 4 times a day or 20 milligrams 2 times a day, doesn't matter. But the point is you're going to taper really slowly at maximum probably 25% of total dose per month. So 40 milligrams this month, 30 milligrams next month, 20 milligrams the following month, you get it. And for some people, you got to go even more slow than that. You go 10% per month. So you're going from 40 milligrams to 36 milligrams. And then next month, you're going to go down 4 more milligrams. So it may take you a year to get off these benzodiazepines, and that's fine as long as you win the race. It doesn't matter how slowly you go. But what you're probably going to need to do in the meantime is you're going to have to find alternate ways to address that anxiety and their insomnia. So that might mean things like a trazodone for sleep or an SSRI for anxiety. There's more on this method. It's called the Ashton method. It comes from a psychiatrist in the UK, and the website address is there. If you Google Ashton method benzodiazepines, you'll find it. So in summary, benzodiazepines are really useful tools, and they've been around in psychiatry for a long time because they work and patients tend to like them. The problem is that they have some real risks associated with them. So ideally, we're only using this for short-term use for a few weeks at most, because the long-term risks to benzodiazepines appear to outweigh the short-term benefit. And so you always want to think about starting a benzodiazepine with the idea of how am I going to get off of this? Always have an exit strategy. Speaking of exit strategies, we are done with this module on anxiety disorders, and I hope you found this helpful. I look forward to seeing you in the class conversation. Thanks now. Bye.